So, with a view to doing the other day, is that what you think?
Other couple of days, I think she's quite keen to just do 3, so...
Oh, yes.
But there's so many recall sessions. I said you almost need half a day or a day just to do all your paperwork.
Been 2 years. I got a few bits and bobs.
Was up till now.
We've got some already.
Yeah. And you see, do you enjoy the break?
She's going to be a practice manager though.
Yeah.
They'll just receive training.
So make a huge difference, why not?
It's not been enough.
They can see her.
So if they're willing, just send them.
We can hear you.
Or just if you're thinking anything relevant, like Marina was saying, any goals you guys have talked about.
I'll leave it on mute until you guys are ready. We're ready to start in 1 minute. Has everyone arrived? Just one's going to be late, but start when you're ready.
Okay. It's not fair for relations. Well, we are in all respects, aren't we? Up here. Just cancelling my
It's quite special. She's not only got, she will be very happy to jump in on any of us, so she'll always have an insight.
Good koto, welcome this evening. Welcome to Patellofemoral up there in the mid and far north. Welcome to tonight's session CME, first CME for the MAPS program. Tonight we've got 2 speakers to do a presentation. That will be the first hour, and then the second part of our evening we're wanting to do a small workshop with you. What's working, what's not working with the program, what are some of the barriers, and we'll do a exploration and how we can follow that. So, without any further ado, I'm going to introduce you to lovely Eve, who's our first speaker.
Okay, my name is Edith Rotkins. I'm professional advisor in physiotherapy for Northern DHB and also therapy. Did they hear me?
Yeah.
Yes. You can hear me? Good. All right, so I will be talking about the knee and the hip, specifically physiotherapy related. And then Grant next to me will be talking about the back and the shoulder. Thank you. Can everybody hear me, see me? Well, not see me, but see the presentation and hear it? Yes? Yes. Good. Okay. All right then. So if we talk about chronic musculoskeletal pain related to knee and hip, the most common ones, the ones that are not covered by ACC would be osteoarthritis for the knee and patellofemoral pain syndrome that are worth considering for referral on the MAP program. And for the hip, osteoarthritis and greater trochanteric pain syndrome. Now, the general principles for physiotherapy for chronic conditions is different than for acute injuries. There will be more emphasis on finding, to get good outcomes, I should say, there should be more emphasis on finding the causative factors for chronicity, any biomechanical faults that may be causative or contributing to chronicity. There will be less passive pain relieving treatments, but more active analysis. There will always be quite a specific therapeutic home exercise program, specifically prescribed to the patient, so not just general exercise, but specifically on the basis of assessment findings. Oh, we're jumping. Hang on, what's happening here? Oh, don't know about the presentation, maybe on automatic slide show, we can hear again. I don't know. I didn't touch anything. And hopefully that will be done, that exercise program on specific objective measures that have been found in the assessment. There will be quite a bit of emphasis on education of the patient about their condition and how to self-manage it. Under control. All right, so let's briefly talk about OA knee and evidence base behind it. So evidence from the Cochrane Systematic Review in 2015, exercise for OA of the knee by Friends and others, states that exercise therapy is among the dominant non-pharmacological interventions recommended by international guidelines. High-quality evidence indicates that land-based therapeutic exercise, note therapeutic exercise, provides short-term benefit that is sustained for at least 2 to 6 months after cessation of formal treatment in terms of reduced knee pain. And moderate quality evidence shows improvement in physical function among people with knee OA. So nice to see that it lasts for at least 2 to 6 months after cessation of treatment. So, physiotherapy and exercise improve in functional outcomes and pain in OA by improving flexibility and by strengthening muscles that support the affected joints. An appropriate exercise program can safely reverse deficiencies in gait, strength, flexibility, aerobic power, and exercise capacity. And for those for severe arthritis and marked conditioning, aquatic exercise can be considered. And this is from the non-pharmacological therapy of OA review in 2016 by Kalunian and others. They also state that the psychosocial evaluation should include an assessment of coping mechanisms, such as activity avoidance and denial, and of symptoms of depression. The impact of psychosocial support may be as beneficial as that of medical therapy. We often think of knee OA in very much mechanical terms. There's some changes on X-ray. The patient has got knee pain. They're directly related, and we need to operate on it and replace that knee. But of course, in OA knee, you also have pain behaviors happening from time to time and wrong beliefs. There may be fear avoidance behaviors or catastrophizing or feelings of anxiety and depression, and if we can include that in our rehabilitation and address that, then it will be beneficial. So what would physiotherapy for OA knee look like? We can stretch relevant short muscles around the knee joint, and there are certain muscles that are more prone to shortening around the knee, such as the rectus femoris, the hamstrings, and the gastrocnemius. There will always be an element of strengthening of the quadriceps and other relevant muscles around the knee, and that may have to be done in a specific individualized manner where we progressively strengthen as tolerated. We can also consider manual therapy to restore joint motion, and that can be restoring accessory glide component of the joint motion. And in that case, extension, the range of extension is important to consider. When we lose our final degrees of extension, the knee will not function as well because the screw-home mechanism of the knee and the internal stability of the knee will be affected. The quadriceps mechanism will not work as efficiently. And also when we walk on a flexed knee, the loading through the patellofemoral joint increases considerably, which in itself can cause pain. And we will always follow that up with range of movement exercises to maintain the gains if we manage to restore joint motion. We can promote activity and weight loss. Consider walking aids, and we can also correct faulty movement patterns in functional activities, and I'll come back to that a bit later. It's important to also consider patellofemoral joint pain in knee OA. The patellofemoral joint may not show any changes on X-ray, but may be the main cause of the knee pain, even when the knee itself shows the radiological changes. And in that case, we can treat that as well. And there will always be an element of a specific home exercise program. And it's difficult for patients to comply with a home exercise program, I don't know if you've ever had to do exercises, but it can be quite difficult to fit it in. So it's important that we measure compliance, that we look at compliance, that we make it easy for people to do their exercises, that it's individualistic and to their needs. And also that we use objective measures so that we have baseline measures and that we can actually see if patients are doing their exercises correctly and often enough to make a real change. For OA knee, we can also consider footwear orthotics. There's some limited evidence for lateral wedge supports and walking aids. And if we can improve function and reduce pain, then activation also becomes important. So it may be a referral to green prescription at some point to increase patients' fitness levels again and to give them confidence in general activity as well. As I said, consider pain behaviors which may increase the pain experience. And with the education component for OA knee, it's important that we talk about avoidance of resting, because if we rest more than 24 hours, it will always have a detrimental effect on the knee. There will be more deconditioning and more weakness that is happening with that. And resting may well alleviate pain, but it should only be used when there's acute inflammation, acute pain, exacerbation, and signs and symptoms of inflammation, such as swelling and redness and night pain and constancy of the pain, but never longer than 24 hours. It's also important that we educate patients that their OA may not necessarily worsen. They also often have a bit of a dramatic view that the only way forwards can be that their knee is going to worsen over time. They've got this wear and tear and it will worsen over time. That's not necessarily the case. Some OA knee can improve functionally and pain-wise, and it's important to have the right expectations there. And it is, of course, beneficial if we can prevent or delay total knee joint replacement. Total knee joint replacement is a very effective surgery, don't get me wrong, but it's still big surgery. So if we can prevent it or even delay it by some years, it will be worthwhile to prevent further revisions and maybe repeated revisions, which are always more problematic. I have the feeling that I slipped over one slide. I'll just go back a little bit. This one I skipped over. It talks about the individualization of the management of OA to the specific patients, to their expectations, their goals, their function, their needs, and to coexisting medical problems. And it also mentions here that resting for longer than 24 hours will be detrimental. And also the statement that in patients with OA knee or overweight, weight loss of even a modest degree may produce improvement in lower extremity joint pain and function. So that's worth if we can achieve that as well, or facilitate that to happen as well. Okay, now I've got it all for OA knee. I can answer some questions at the end. It's probably easier than throughout the presentation. Okay, that brings me then to Patellofemoral pain syndrome, which is also a very common pain in the knee joint and often not covered by ACC. So those are the people that have anterior knee pain worsened by stair walking, particularly downstairs and downhill worse than uphill and upstairs. They may also have the movie-going knee sign, where if they sit prolonged with their knee flexed at 90 degrees, that irritates their knee. It's more common in females than males, and it's also quite common in teenagers. So what is the evidence saying there? This is again a Cochrane review 2015 by Van der Heijden. There's low quality but consistent evidence that exercise therapy for patellofemoral pain syndrome may result in clinically important reduction in pain, improvement in functional ability, as well as enhancing long-term recovery. there's still insufficient evidence to determine the best form of exercise therapy. And in recent years, there's been more emphasis in analyzing and treating hip muscle dysfunction as well. See, it jumped again. So there's now some very low quality evidence emerging that hip plus knee exercises may be more effective in reducing pain than knee exercises alone. Okay, so the physiotherapy principles for patellofemoral pain syndrome will be to restore alignment of the patella movement in the trochlear notch of the femur during motion, and the common fault there is lateral tracking and tilt of the patella. And that goes hand in hand with addressing common biomechanical causative factors, such as a faulty movement pattern of medially rotating and adducting your femur when you're bending your knee and squatting, which is also an increase of what we call the dynamic Q angle. And I've got a picture of that to make it a little bit clearer. Oh, jumpy. Okay, so this shows the correct way of bending your knee and the incorrect way of bending your knee. So the left one is the correct way. That person is keeping their pelvis level, and then their knee bends over their second toe. And if you follow the line through mid-femur and mid-patella and project that line to the ground and see where it meets the ground in relation to the floor, that line should really reach the second toe. The right picture is the common faulty movement pattern that happens very often. So firstly, the control of the pelvis is reduced, the pelvis is not kept horizontal and stable, and then the femur medially rotates and adducts. And if you follow that same line through the femur, that line will be pointing to a point on the inner side of the big toe. And that is wrong for the patellofemoral joint, because your contracting quadriceps will then exert a lateral pull on the patella. This can be caused by either a weakness of hip muscles, the external rotators and the abductors of the hip, or it can be caused by excessive pronation at the foot, or both. Because it's a whole biomechanical chain of movements, your whole lower limb. And as for the foot, so if your calcaneus goes into valgus with the pronation, your subtalar joint is a torque converter, and that will convert the movement of the calcaneal valgus into an internal rotation of your tibia and your femur, and that's where that movement pattern comes in as well. The next picture again shows that on a person. And maybe you can see, it's a little bit hard to see there on the screen, that the pelvis, that she's losing pelvic control, so her trunk is going sideways, so it's likely that she's got weak hip abductors. It looks like the pelvis is rotating away from it as well, but it's hard to see on that picture. And if you follow that line through the femur, you can again see that it projects not to the second toe, but to the inner aspect of her big toe. And we can correct all that. And then it usually improves when we do. Okay, so we talked about that first point in the foot pronation. Then for patellofemoral syndrome, the weakness of the VMO is also very important to address. So that's the vestis medialis obliquus of the quadriceps. And you can actually activate your VMO in isolation. It's got a separate innervation, so you can actually learn to activate the VMO in isolation from the rest of your quadriceps. And if you have an imbalance of vestis lateralis to your VMO, that also gives the wrong pull on the patella, laterally. So sometimes you have to activate VMO, but consciously relax vestis lateralis. So the hip needs to be assessed, the strength of the external rotators and the abductors, and if there's weakness, that needs to be addressed. And it's also beneficial to look at muscle shortening around the knee, hamstrings, rectus femoris, gastrosoleus, and also the lateral retinaculum of the iliotibial bends, because that will place the patella in a lateral position in the first instance. So the individual assessment and treatment for patellofemoral pain may include manual therapy of the patella, which is usually restoring the medial glide of the patella. We could use McConnell taping for the patella as well, just temporarily initially to promote better movements. And that McConnell taping has been shown to reduce pain, facilitate better tracking of the patella, but also facilitate VMO getting into more activity. Talked about the VMO, muscle length, strength, and again, that correct faulty movement patterns needs to be corrected in normal daily activities for the particular patient. So they need to learn to bend their knee correctly when they're stepping up and down, when they're squatting, and even going up from sitting to standing and standing to sitting. Okay, that brings me to the hip. Hip OA is a bit more controversial, the evidence, than knee OA. We saw that knee OA, the evidence for physiotherapy is quite strong, but for hip OA there's conflicting evidence. So there was a Cochrane review in 2014 by Frentzen and others, and that stated that land-based therapeutic exercise programs can reduce pain and improve physical function among people with symptomatic hip OA. So that was quite positive. But then came the study by Kim Bennell and others that was published in JAMA in 2014. The effects of physical therapy on pain and function in patients with hip OA, and that was also reviewed in the GP research review, one of those online things that comes around. So basically it was a big randomized double-blinded control study for 102 patients with painful hip OA, so it had statistical power, and they were randomized to either 10 physiotherapy treatment sessions or sham treatment. And the sham treatment was inactive ultrasound treatment by physios and inert gel. And there was a 12-week intervention program. And physical therapy did not result in greater improvement in pain or function compared with sham treatment. Ouch. Raising questions about its value for these patients. So then there was also a commentary in GP research review that maybe the money should be better channeled in increasing timely joint replacements for hip OA. But when you look at that study in more detail, it's quite interesting. Actually, both groups, the sham treatments and the physiotherapy group, showed significant improvements in pain and function. So it wasn't all that bad following treatment. So both in terms of reduction of their visual analog scale pain rating and in their WOMAC score of physical function scores. But there was just no significant between group differences. Still not very good, but okay. And they were analyzing that too, and they suggested that the sham intervention must have been pretty credible and effective, and creating a significant placebo effect to have those results. And if you look at the sham treatments, there were still individual sessions. There were 10 individual sessions, and it did involve skin stimulation and touch and an attentive therapist, and patients having confidence in the treatment that they were getting the placebo effect. So maybe that just showed the evidence of the quality of therapeutic relationship influencing outcomes. But it's not a very, still not a bit of a mixed findings for physiotherapy intervention. But it was physiotherapists that did those individual sham treatments as well. Okay, so, and then the more recent, back to the GP research review, that sort of was quite scathing, that there was actually no point in it, but we mustn't, in sending people to physiotherapy for hip osteoarthritis, but we mustn't forget that there were still considerable benefits for patients. Okay, so it's a bit hard which way to jump, but I think we can conclude that exercise may not be as effective in reducing pain and disability in patients with hip OA as in compared with knee OA, and I think most physios would agree with that. But again, weight loss of even a modest degree may produce improvements in lower extremity joint pain and function, so that should always be in the back of our mind. And other methods of unloading an osteoarthritic joint includes canes and walkers, which can reduce joint forces at the hip by as much as 50%. So that's significant. Okay, that brings me to greater trochanteric pain syndrome. I've got no idea how I'm going for pain. Am I sort of... Okay, I'll do my best. Okay, so greater trochanteric pain syndrome is one of the most common causes of lateral pain in adults, and we used to call it all trochanteric bursitis, but that's a bit of a misnomer. Because with more advanced studies, they've shown that it's usually due to a tendinopathy of gluteus medius or minimus, with only variable involvement of the regional bursae. And actually the trochanteric bursa is very rarely involved, so I'll skip over that one. So how do we treatment? It's probably best to use principles of treating tendinopathy and when we treat these lateral hip pains. So again, abnormal biomechanics while performing common tasks, just for the hip, running, jumping, walking, often contribute to tendinopathy. And ideally, such potential abnormalities should be assessed by an expert and corrected wherever possible. And I'm quoting here Karim Khan, Carl Fields, and Jonathan Greitzel. And Karim Khan is quite well known for all his textbooks on sports medicine. In general, the biomechanics of the task responsible for the tendinopathy should be analyzed and optimized, and the treatment approach has not been studied in large randomized trials, unfortunately, but is supported by clinical experience. So physiotherapy, I'll go over that quickly, but we can assess often findings in these pain syndromes is weakness of gluteal muscles and external rotators of the hip, which we can assess and address. Then with the faulty movement pattern of the internal rotation of the lower limb, we can do something about that, and excessive pronation the same. There's often a finding of limited range of hip flexion in these lateral hip pain syndromes, greater trochanteric pain syndromes, not because it's limited by pain, but it's just limited range. So if that's a finding, then we should stretch it or use manual therapy for that. To address relevant muscle imbalances around the hip is important, and there are certain muscles that are more prone to shortening and certain muscles that are more prone to weakening, but we can assess those. And sometimes it can be a leg length discrepancy, either apparent leg length discrepancy or an actual leg length discrepancy that is causative or contributing. So that was my presentation on hip and knee. I'm very excited that hip and knee are included in the referrals for the MAP program, and there's been a limited pathway for patients that are not covered by ACC and have chronic musculoskeletal pain for hip and knee. And it's really exciting that they can be referred for treatment. And it's, I think, a bit of a sad prerogative that with that strong evidence for knee OA, that so many people end up with knee replacements without ever having been able to access simple conservative treatments, which may have made a big difference some years prior to that. Okay, have you got any questions? I'm getting off lightly.
Yeah, hope this.
Oh, okay. Yes?
Can you hear me?
Yes, I can.
Do you have a program, exercise program for the overweight clients? You know, there's so many out there that are
Yes.
overweight and they can't have operations or things like that because of their weight. When they come to you, do you have a program to say they could lose their weight?
It's limited. Probably I would think a green prescription referral would be the best pathway, but it depends a little bit where you are in Northland, which will do the whole package of generalized exercise and nutritional needs.
Can I ask where you're based in Northland, sorry?
Where are you based in Northland?
In Northland, Tauko Hospital and Ngāti Health Trust.
Yeah.
There is some.
Yeah.
There's a program in the mid-north.
So
Yeah.
Mark's visiting Kawakawa Kirikiri every week to see people up there, and basically one-on-one support with physical activity and nutrition.
Oh,
Hear
okay.
that? Could you hear
Yes,
that?
I hear that.
Okay, yes. And also with the MEP program, of course, those patients that have been declined for surgery because of their weight may well do with referrals to this program, where they should still get some relief. And if they start to function better and have less pain, they will also have more. It will be a little bit easier to lose that excessive weight, and maybe later be able to qualify for surgery.
Okay. Is that all in these books? I mean, your referral system in there?
I think that will come at the latter end of the session. They will talk about the referral systems and those sort of things.
All right. Thank you.
Okay. Another question? Yes?
Not a question, just enforcing your talk on the hip osteoarthritis and hip replacement. I had bone cysts in my hip joints, which started when I was nursing and had to stop nursing, and had a couple of bone grafts, and then finally a hip replacement when I was 40, which was about 12 years later. It would have been wonderful to have a program like this, just really for pain relief as well. I found that exercise made it worse, and so I did lose a lot of muscle condition. The pool was the best thing for me. And Kawakawa Pool now has access by a tiered ladder. So I would just recommend hydrotherapy because the pain is horrendous. It's like sciatic pain that doesn't stop. And the physio afterwards too would be really good, to follow that through so that they do strengthen the muscles again. So I just really, I can't think of the word, congratulate you on starting a program like this, because it's a lonely journey.
Oh, well, it was the ministry, of course, that made the funding available. So, but it's really neat that Northland won this first year of the contract by the ministry. Yes, and hopefully we will get really good outcomes, because ideally on the long term there should be some funding for non-ACC musculoskeletal pain on the long term basis. It's well overdue, I think.
Yes. Thank you.
If there's no more questions, then I'll hand it over to Grant to talk about the back and the shoulder.
So we all sit up straight.
That's great. Green prescription. Because
Now, you might have think I've come to the wrong evening. No apologies. My talk is really geared more towards general practice for low back pain, because I think the physios are pretty up to speed with managing low back pain and assessment. I'm concerned about in general practice because the guys have got so little time, it is so complex, and you need to have a little bit of a system in how to deal with this. So we've got ECGs made easy, and I've got low back pain made easy in 6 simple steps under 7 minutes. So someone timing me. And I'm not going to tell, this is not an instructional talk. I'm going to put a few challenges out with some of the problems that I see on referrals. Firstly, an accurate history, and that's the usual pain history that you take for any presenting complaint. And one of the most useful things is a pain map. So to have some of these on your desk just to get the patient to copy in. I mean, the one on the left obviously, well, could be radicular pain, not necessarily. The one on the right looks like a very distressed person. Now, if you don't have a pain map, it's not always easy to tell. So what is the type of pain? And is it somatic referred or radicular, which are the two big ones for low back and leg pain? And often it's unclear from referrals what we're dealing with. And how do you tell the difference? So you have to come to my advanced course to learn how to tell the difference if you don't know already. So in general practice, GPs are in the best position to rule out the red flag conditions. I know the physios do as well, but general practitioners have the patient's history, and so remember the red flag conditions, so fractures, so strong bones and large trauma, or weak bones and minor trauma, visceral referred, of course, tumour in the people that have had a history of cancer, infection in anyone that's had body penetrations, and that could be things like needle use or tattoos or medical intervention. This is a good general practice question you ask every time, what is the patient's agenda? Because it'll be quite different from the practitioner. Why have they come? In a study in Australia, 1 out of 18 people with chronic low back pain presents to the GP in a 6-month period. Why does that one person present and the other 17 don't? Why do 3% of people with headaches present to their GP and the other 97% don't? So what is the patient's agenda? And pain is not always the most important factor. This, you won't be able to read this on the overhead, but basically this is looking at odds ratios for low back pain. And if you, I'll read just on the top, the female gender odds ratio of presentation for low back pain is 1.67, which is really nothing. Age 1.31, nothing. Job satisfaction 0.95. Pain intensity only 1.92, so it doesn't really rate. Disability intensity 3.87, and high levels of disability 7.66. So pain-related disability is far more important than pain intensity for an explanation why the patient presents. And then, so that leads on to trying to find out what it is that they are concerned about and addressing those. Now, an appropriate examination, and I encourage everyone to sort of write down on the back of an envelope what they think they should be examining each time and stick to that. I have a template that I use every single time for examinations of what particular region I'm looking at. But for example, if you're going to pick up if someone's got radicular pain from the history, not from the examination, so you don't have to do a neurological examination every time. It's a waste of time. So you want to do an appropriate examination based on the history, what pathway you're going down. And tailored management. Do you investigate? When we irradiate so many people, a couple of big studies, both with about 5,000 subjects, participants, for low back pain, the x-rays only had a bearing on the outcome of about 20 in each group out of 5,000. So we're irradiating an awful lot of people. And if you're in Australia and you've got low back pain, you'll get a CT scan, which is really a waste of time. When do you refer? Or should you, if you're reassured that the patient is maybe under 50, they haven't got any history of cancer, they've got no red flag conditions, then it's appropriate to take a functional approach. and that could be encouraging exercise. It could be using some other McKenzie technique, Mulligan technique, all those sort of encouraging activation. How useful are analgesics? And analgesics, I see people who've had random steroid injections into their butt or something, I'm not quite sure why. How useful is oral analgesia for somatic low back pain or for radicular low back pain? If somebody's got sciatica, they need an epidural smartly. There's not even much you can do manually, maybe acupuncture, but I'm not convinced that manual therapy for good going sciatic pain is going to be very useful. Counter-irritation, manual therapy, and then finally, if you're in general practice and you've got someone with really severe low back pain or radicular pain, book a review, because just because they don't come back doesn't mean that they are pain-free. There was a study in the British Journal of General Practice that showed that. So book a review and get them back. And fortunately, most low back pain is benign. There are not too many nasties out there. Does anyone want any comments or questions at this point? Apologise for OTs and physios and stuff. I'll keep the next one as short and sweet. So, shoulder disorders. The patient's going to present with usually one or more of a combination of those 4 symptoms. And just remember, there's a lot more to the shoulder than the glenohumeral joint and the rotator cuff. Don't forget the AC and the sternoclavicular joints, the scapulothoracic articulation, and of course the rotator cuff. So you can sort out shoulders taking a sort of pathoanatomic approach, like so. And always listen to your patient. He's going to tell you the diagnosis. The 5 traditional diagnoses that we deal with, and clinically, there's little clues, but everyone has a sort of a preoccupation with rotator cuff disorders. But clinical examination shows that our tests have got very poor, generally low sensitivity and low specificity, resulting in very poor likelihood ratios. And one of the common mistakes I see is people coming along with pain like that, and then they've gone along and had an ultrasound and there's some tendinopathy, then they've had a steroid injection or 2. That is not rotator cuff pain. And when you do investigations, you find that a high proportion of asymptomatic people do have partial or complete tears. So, and in a study comparing a group with clinical impingement and age-matched asymptomatic individuals on MRI, the structural pathology was identical. So it comes back to the history. Now that's cut off a bit, but I expect the physios will be very familiar with Jeremy Lewis' approach of shoulder symptom modification procedure. Tina? You know, with the humeral head, so replacing that with you and going through your abduction or elevation or whatever. Same with the posture, trying to postural correction. So I think that's again, don't forget the red flag conditions. Again, this is sort of more for general practice, but for the physios. And referred pain, and don't forget possibility of brachial plexopathies and crips, and not that we see crips that much in the shoulder area, but natural history of shoulder pain is that at 18 months, 50% were pain-free and 50% still in some degree of pain. Frozen shoulder, the vast majority have improved at 2 years, but a lot of people still have some minor residual restriction. And a big part of my work is exercise and is education and reassurance, and all the therapies that are available to us. And surgery. When to refer early, so red flag conditions, obviously, somebody in severe pain or distress, where there's significant weakness and in the young possibly. That's it from me. Any comments or questions?
Actually, again, if I just... Oh. Otherwise, I can say a little bit about physiotherapy for chronic shoulders. Sorry? Is that okay? Yes, yeah, you mentioned a few. Yes, so there's... we look at quite a few muscle functions around the shoulder, again, to look for the biomechanical causative and contributing factors in the shoulder pain. And common findings are shortness of your pectoralis minor with a protracted shoulder, and that really affects your shoulder. That's really problematic. I don't know if you want to try that for yourself, but if you just abduct your arm through the range, just freely, if you haven't got a shoulder problem, you will be able to do that quite easily. Now, protract your shoulder, just pull it forward, and now hold your shoulder like that, and now try to abduct your arm, and just see what that feels like. Do you feel that? It's really quite uncomfortable. So if your shoulder is permanently, if you're always in bad postures and your shoulder is permanently protracted forwards, that your shoulder will not get better. That in itself is the reason. And often that starts to shorten too when you're in pain, because you often go into protective mechanisms to guide your arm, and then your shoulder goes forwards, and then you've got a vicious cycle that starts to happen. Your shoulder blade muscles are also so very important for good shoulder functioning, because it's not just your actual shoulder joint, your glenohumeral joint that takes part in the movement, but as Grant says, it's your whole scapula needs to move too, so your shoulder blade needs to move upwards, outwards to be able to get your arms right up into full elevation, and quite often those shoulder blade muscles have weakened, and that upward lift of the shoulder blade is not present. And again, that has an effect on shoulders and internal pathology and inflammation in the shoulder. And some people completely treat their shoulder the wrong way. They can learn not to reach behind them for their heavy objects because of the long lever arms, and to store objects, the heavier objects, not so high, to step up a step. So that's important. And manual therapy has got a role too for the shoulder. So if it can also be the humeral head that sits too far forwards in the glenoid cavity because of tightness of the posterior capsule. And if we stretch that, we can often restore painless range of movement as well. And I've got a little statement here, if I can read that out. Is that okay? The Cochrane Review of 2016 for manual therapy and exercise for rotator cuff disease. Effects of manual therapy and exercise may be similar to those of cortisone injection and arthroscopic subacromial decompression, but this is based on low-quality evidence. So there's definitely a role for that, and if with a simple conservative treatment we can avoid those higher risk procedures, then it's worthwhile, I think.
It's a bit like low back pain. There's subgroups of people that respond to different treatment, and it's finding it's trying to work out which group people are going to fall into. But empirically, you end up trying them, don't you?
Not always. I think there are lots of people with chronic back pain that never have it analysed, unfortunately, because it's not covered.
No, what I mean is, like for shoulders, some will respond dramatically to a corticosteroid injection, and then others won't respond at all. So there's no way of telling without actually trying.
No, that's right. But then again, if you do get good relief from your injection, then it may, if your biomechanical faults are still there, then it may come back, of course, your problems once that is worn out.
Question. So the MAP program is now currently going to address people's needs for hip, shoulders, knees. When in the future do you see this program supporting individuals in the community with osteo in their spine, in their lower back? How would a person be referred to that?
No, this is included because back pain is included. Okay. Chronic back pain, not covered by ACC, longer duration than 3 months is included, or 6 months? 3 months or 6 months? Can't remember, maybe at the back later.
I'm not sure that osteoarthrosis of the spine is a diagnosis, because it's something we all have, we all get with age, and there's very little difference between the symptomatic group and the asymptomatic radiologically. We all get osteoarthrosis.
I just had a recent visit from a member of in the community, and they were talking about their pain. And it wasn't to the practice that I work at, it was just in a general meeting somewhere. So they talked about osteoarthritis in the spine, and they were diagnosed, as they said, from their GP. But so it's just a question really, so the people that have lower back pain, it's considered arthritis or osteoarthritis, they can be referred to the program.
They can.
Okay.
They can, yes, yeah.
Thanks.
And with the evidence there, unfortunately there are no big international guidelines on chronic back pain. There are international guidelines on acute back pain, but not on chronic back pain. And all the studies are a little bit non-conclusive, really. It's quite a big group of people when you study chronic back pain. There are lots of subcategories, and they can't very well decide on the subgroups, but anyway, that's a little bit by the by. But there are a lot of people with chronic back pain that need to be educated about how to treat their back, how to take good care of their back. It's not something that people naturally know, how to lift safely, how to sit in good postures. And sometimes, they have some idea about how to lift safely, not twisting your back and bending your knees, but they haven't got the strength to do it properly. So it may be that firstly we need to strengthen their quads and their glutes so that they can actually bend their knees and pick up objects in a safe manner, not to continually overload their back. Then there's some people that have stiff hips, that haven't got enough hip flexion range for various reasons. They've just become stiffer for whatever reason. They're going to be overloading their back in flexion movements too. Every time if you want to get to your feet, put your shoes and socks on, and if your hip doesn't bend enough, then you're going to be doing excessive bending from your back. So sometimes we actually end up treating other parts of the body to actually get an improvement in the back pain and functioning.
Those people with osteoporotic compression fractures, are they going to be?
No, I don't think they're going to be. No, I don't think so. I don't know where that exactly sits, but that's probably more the red flags. That's probably not, your simple mechanical back pain. But I'm not 100% sure. I can't fully answer that. Maybe Aniva can answer that one better.
Is there any more questions before we move on to part 2? Any more questions from Kitty?
Shall I just show these rubber bands, because there were some for the providers for exercise therapy. You may want to consider the MET program is going to supply you with these simple rubber bands instead of the more expensive TheraBands. And they can be cut, I don't know if that lot can see it, they can be cut in half so that you have less resistance. And these things are of less than $1. Well, they're quite cheap, so the MAP program has decided that we can fund it. And they can be strung together to, if you need to make it longer. And people can just attach it to a doorknob or a sliding door, or a towel rail or something to provide the resistance. And they're quite useful for shoulder, rotator cuff strengthening, or for other parts of the body.
So Manaia has put an order in for Northland, and as soon as it arrives, we will be sending some out to all the providers. So we'll let you know when they arrive. Well, thank you very much, Grant and Edith, for your presentations. That was excellent. Thank you. Or do you want to come up here? So, sorry, I forgot to introduce myself earlier. Tania Pritchard, the Clinical Services Manager. So my role in this program is just oversight of the pilot program that the Ministry has implemented for a 3-year period. And Audrey, who's just coming up here, is supporting the IT process around the program and supporting providers around the referral process and how to use the IT platform, and also coordinating referrals. And just over the back there, I'd like to introduce Laura, who is our triage nurse who works with the Primary Options program here at Manaia. So when your referrals come through, Laura will triage them, and then they come over to the coordinator. So Aniva sends her apologies. She was unable to make this evening, and this is actually her presentation. So I'm not going to talk to it much. I'm just going to let you read it. But she gives a little bit of background. Can I get you to bring it? Oh, yes. A little background about the program. So this is a pilot program for 3 years. Northland was one of the providers that went out in tranche 2. There's actually 7 phases that it's being rolled out. We've been part of the pilot for 6 months so far, so we've only got 2 and a bit years to go. Over the 3-year period, it's seen that Northland can provide interventions for 500 patients. To date, we have had...
Sorry. I don't know how to make it bigger.
That little...
It's not very... It's a bit cut off.
Okay, can you just press through the slides? Yeah. Okay, so it's an e-referral platform, and Ord's going to take you through just where to find that on your systems. And basically there's 3 options available for patients. There's tahiru and toru, and we'll go through that a bit more detail. Can you come on to the next slide? So that's the criteria. I'll let you read that for yourselves. Can you see the slides up in Kirikiri?
Yeah.
Yeah. Next. So I'll let Ord talk to the e-referral platform.
Okay, so kia ora koutou. So I've got a few different screenshots here, and I apologise, they're a little bit hard to see. So this first one here we've got, which would be from the practice end. So we don't have too many practice staff here, but you would launch the form by going into an advanced form and choosing stepped care NFOS form there, which will then take you to this process here, where you will use your login, and that login is personal to your practice, but it's also the same login that you use for CVD and diabetes screening and stuff like that. But I have all of those if you don't have them, and which will then launch this pad here, which is how you enrol your patient. And that pad also will let you manage your patient, so it will let you hop in there at any stage and click on Manage Patient and see where they're at. It will open the actual referral and tell you which provider is seeing them, what sessions have been provided to date, and so on. So there is a user guide which is probably a little bit more. There's two separate ones here, so we've got a bound copy, which is this one here. So that's the Mobility Action Program Service Provider role. So those are for our external providers. And then we had a stapled one which was called a Quick User Guide for practices. And I've left some business cards on the table as well, so you can call me at any stage and we can do a phone lesson, or we can come out and visit.
Has anyone got any questions about that before we move on? So Audrey is your person to contact if you need support with that.
How are you finding it, Tina? Tina was probably... Yep. So one of the good things about the referral system is it has the accounting package attached to it. So every time you provide a session, not only does it tell us what you've done with the client, but it also tells us how much we will pay you. And that will, generate a BCTI, which is run the 1st of every month, and then you'll get paid the 20th of that month, depending on what sessions you've provided.
So you don't have to wait till it's all closed off. You
No.
get paid as you know.
No, you get paid monthly.
It's run every month, depending on what activity has been provided the month before. Things I can't do is I can't remove a session if you provide one in error, but I can contact Enigma, who has designed the program, to do that for us, and they're really friendly, and that happens quite quickly. I think that's probably about it.
Yep. We'll move on to the next one. So here's the packages of care. So under Tahi, there's a value of $300 applied to those packages, and up to 5 sessions. And those are the types of interventions that can be utilised in that package. Under Rua, that's a $500 package of care. And then under Toru, that can be up to $1,000 per patient. And those are more complex patients and that.
Can I ask a question at that point?
Yes.
If you, I was just talking to a therapist the other day who was given a client who proved to have a very complex history but was brought in at Rua. If you discover your client's much more complex than the triage has determined, are you able to ask for a change in the designation?
Yes, you are.
Good.
I guess that probably just takes us to a point where we remind you of good referrals in the beginning. So if you think your patient is perhaps at that Rua or Toru level, if you can provide us with as much information as possible for the triage team to make a good decision about that as well.
So the next one is just a case study. I'll let you read for yourself that Aniva has provided.
It's a bit hard to read.
Can you read it out, please, Lord?
So it says that a Māori woman in her 50s, struggling with knee OA, limiting what she can do with her whānau, completed a tahi level, and patient feedback was it was simple, things the physio showed me, just a different way of getting up and down, out of a chair, which has changed pain levels and feels much stronger and able to walk. Green prescription given at the end of program, and this patient continues to attend the pools through that.
The next slide, Aniva's just given an example of the process from a general practice point of view. A patient comes in for usual meds. It's noted on their file that they have OA from an X-ray last year. GP inquires how their mobility and pain is going. They've been struggling a bit and taking paracetamol, Brufen intermittently to try to manage. GP books them in to see a practice nurse to complete the e-referral process for MAPS and also gather extra information. The GP uses PHO query build. This particular next point that Aniva has made is that within her practice she's done a query build to actively recall patients for a booked appointment, where the e-referral to MAPS can be completed if they meet the criteria. So I just wanted to give some feedback. Last week we met with the Ministry of Health around the pilot program, and we're probably quite unique compared to other programs that have been rolled out across the country, where most of the other programs are group type programs led, where our program is quite client-centred and designed around the individual client's needs. So it's probably more complex. So some of the processes around the model of care have, along the way, we've found created some barriers, and so we're in a process of reviewing what does that look like, what do we need to change to remove those barriers. So one that we have discovered that's created some barriers is the MDT process that needs to take place for patients to be able to access a rua or toru package of care, and some locations have been quite slow to get their MDT process up and running, so that has created sort of a backlog of patients waiting to basically have an assessment done on what their needs are. So really wanted to put to this group, what are some of the things that are working well with the pilot, what's not working well, so that we can tweak our model of care to remove those barriers so that clients can have access and speedier treatment process. Is there anyone want to?
I'd happily jump in. Firstly, no referrals have been seen at all. No contact with GP practices have been followed up. So it's not actually happening. And I think that's possibly true for others in the Bay Area.
Yeah, we haven't received any yet.
I received one, but it was for Whangarei, so I sent it down there.
I've received one, and I'm going to see it next week, and it's a Tahi referral.
Yeah, so do you mind saying what location you're in so that we can just... Whereabouts are you based? Kerikeri?
Yeah. Kerikeri. Well, I've got one. I'm linked to Kerikeri and Kawakawa. Not Kawakawa, Kaikohi, sorry.
In Kerikeri as well. But, I mean, in fairness to the GPs here, I've put them on hold because we haven't been in a position to take the referral. So I know that they have a few waiting.
Okay. Anyone else?
I've had quite a few referrals, and not one of them has had anything attached from a GP, any scan, any X-ray, any ultrasound. So we're just getting a diagnosis of NEOA, and we just have to go with that because we can't access the films unless we've been taking it at TRG, but a lot of them have been done at hospital, so we can't get them. So we don't know. Is it the thing to attach any scans or X-rays? So I haven't had one scan or X-ray to look at.
I must say when I'm triaging referrals, I can't recall what the might be.
No.
Something like that on to physio or surgeon.
So I'm hearing there's some consistency in poor referrals being received.
Probably had a look at 9.
9.
There's not been one report text.
I have 3, but I've only seen one of them so far. But it was it's Lucy. I didn't know you did.
Oh, yeah. It's difficult to hear if you're actually speaking to the whole group.
Hi, sorry.
Can't hear you.
It's Lucy. OT. I've had one person that I've seen, and I've got 2 others to see tomorrow. Usually, there's not that much information. The initial interview, if they haven't already seen, sometimes they're not down to see a physio. I've got one that hasn't seen a physio, and it's just for OT. And the initial assessment form, I assume it's for me to complete, but it's quite limited the number of sessions that I have, so it's going to take up quite a bit of time to do that as well as my assessments, and yeah, so it's complex.
You know the health and wellness questionnaire?
It's not
Yes.
is it?
I thought that was the GP was to do that.
I
Again, I haven't had one of those filled in,
No,
so I've been doing it. But yeah, it takes up extra
Yeah,
time.
that's the thing. Before you've even started on what you need to do, time is very limited with the clients.
I know I haven't done any of them, but I know that we've had nurses asked to do them by GPs who actually couldn't work their way through the form and didn't seem to be able to get any information from anybody as to what they were meant to be doing. So I think that may be part of the problem, that people actually don't know what's expected of them at the referral end.
Okay. And that's the health and wellness questionnaire.
I personally haven't done any, but I know that we had a situation where a nurse was asked to do one, and several nurses looked at it and they couldn't work out what they were meant to be doing. So they hadn't actually had the basic instruction in the first place, and they didn't know anything about the problem, and that's why about the program, and that's why I've come tonight.
Okay. So there's 4 pre-screens and post-screens that the ministry are insisting that we carry out for every referral. That's partly how they're evaluating the outcomes of the program. So what I'm hearing is we possibly need to have a CME around the screening tools.
Yes. Yeah.
Yeah. I think they're going to be your outcome measures, aren't they? They're going to be like, you'll look at pre and post.
Yes.
So it is quite vital it's done correctly, isn't it?
Spirit talk for the GP, we've got 15 minutes, it's normally probably the 4th problem they present with, in addition to all of the medications they want done and a whole lot of other bloods and things that need doing, and plus about 7 lesions frozen with liquid nitrogen, and this question and the questionnaire done. So, unless it's going to take a minute or 2, we're struggling for time, or it's going to have to be done at night. Between 11 and 12 o'clock at night.
Jeff, that's why this GP had asked the person to come back and talk with the nurse, but the nurse had no information about what she was meant to be doing.
The logistics that we've got now in general practice, especially here in Northland, where we've become God's waiting room, is exactly that. We're just getting killed with all these elderly, and it's just the nature of the game. But when we're asked to do questionnaires on top of, what is effectively 2 consults, 2 or 3 consults jammed into 15 minutes, sometimes GPs will be.
And how long would it take you to do the questionnaire?
So what I've started doing is I've printed them out, and I'm going to get them hand it out with the consent form and ask the people to come in 10 minutes earlier to do their consent form.
Whereas we have 15 minutes and that's it, gone, up the door again.
Yeah.
I think they're quite easy for the client, as long as they can read and write, it's fine for them to, it's quite self-explanatory, isn't it? The actual, you just rate where you sit on a 1 to 10 scale on lots of different things, but it's quite, I think it would be quite easy for them to fill out themselves, most clients.
Out of their room.
Yes.
Probably.
Yeah.
Yeah, one's a pain rating scale and the other one is
There's self-efficacy.
Yeah.
Yeah. There's only 6 questions, that one, and then there's another one which is a bit longer, isn't it? A wellness one.
Yeah. I mean, I just was clarifying who's supposed to be doing it. I'm happy to do it.
So generally, ideally, it would happen in the practice environment, and I know that because that hasn't happened to date, that it's ended up being the provided as part of the session. You've taken a whole session up dealing with collecting all the pre-assessments before you can get into the treatment. And these are some of the things that we want to know so that we can rectify and improve on the model of care going forward. So thank you for sharing. Is there any other barriers that people can see?
I don't think it's really a barrier, but a lot of the clients are actually really quite complex and they've got a lot of issues going on which are all impacting on their pain. So it kind of does take a bit of time to get to know the client, for them to, to build rapport with them and to actually try and work out exactly what's going on when there's obviously quite a lot of psychological, there's a whole mixed, because, pain, as we all know, is pretty complex. So that does take quite a bit of time, and when you've only been allocated 2 sessions, which I have, it's like, I'm not really sure realistically how much as an OT I'd be able to achieve in 2 sessions.
Right.
Yeah.
So a way forward would possibly be, and some of these ideas, this is what we want to take back to the ministry, is looking at 1 session being around that assessment process.
Can I just mention something from this end?
Yes.
Hi. So I'm a physio, I'm Robin. I know from speaking with the GPs in the Kerikeri Medical Centre that there's a little bit of confusion as to what the correct procedure is for them, which is what I'm hearing from your end as well. There's a big cloud. I almost feel like they want a separate meeting just to find out now if this is serious, what exactly are they doing? And I'm still really unclear, to be honest. I want to get this going, and I think it's very important, and I'm still not clear of the steps of the procedure, and I know they aren't, so that's a big question mark.
Yes. So we're very aware of all these issues. Part of the issue has been that this particular pilot had never had any kind of FTE allocated to it. So the team that I've mentioned, we've all just kind of come together to try to get this going. So we are in the process of kind of renegotiating with the ministry around that. So what I'm hearing is that there obviously needs to be some backtracking and looking at what is the process for someone to be referred into the program and how do they access once they are identified, and how does what was the other?
It was also just around what we can actually provide and not provide. I'm not really sure how much I can provide, not that you're going to need to be using a lot of equipment, that's not what the focus is going to be, but somebody who's quite elderly and occasionally may need something like a shower stool or something like that, and if there's any funding available for that sort of thing.
Right, not currently, no.
Yeah. because that's something that could make quite a difference to someone. And it's like, would they need to be then referred to community OT to then get a shower stool when we could be providing it to them? Yeah.
So if they're in the complex,
yes,
like Rua or Toru,
yeah,
there is some scope within that funding if that is part of the treatment options that are available to them. But in the Tahi package, there isn't any room for that.
I think we, as OTs, more in the level 2, 3.
Yes.
So we'd probably, but we'd just liaise with Audrey, would we, about that? Or?
Yes, and it is around, so currently you would liaise with the MDT process, but this is something I wanted to raise tonight because we really need input, that we are thinking of actually cutting that process out because it's creating a backlog for patients. So what we are hoping is that from the general practice end that they make some decisions for with their patient around what would be the best options for them around a treatment plan, so that then they can just go straight to the providers to provide what is required. So currently the process is it comes back to the MDT and they make the decision around the package of care. But there will be...
Sorry, can I ask, when you say MDT, what disciplines are involved?
So my understanding is up in Kirikiri they haven't quite got off the ground with their multidiscipline team meeting, but here in O2E5 they've got O2E Home, they've got they have GP, pharmacy and physios, they've got mental health input, what else is on there? There's podiatry and OT, yeah. So it's quite a mixture. And in Broadway, they also have a similar process there. Theirs is not as large. They also have nursing around the table as well.
Can I just ask something? You mentioned the weight management that's going to be developed, fortnightly weight and standardised handout. Has that actually been created yet? The under Tahi, weight management, fortnightly weight and standardised handout for advice to be developed by the governance team. Has that handout been done yet? Or if so, could I have a copy?
Could you say that again when you talk about weight management?
Well, when you look at Northland Macro, under Tahi, point number 1, 2, 3, 4, it says weight management, fortnightly weight with standardised handout for advice to be developed by the governance team. And I wondered if that had been developed yet.
I'm just trying to grab the form so I can refer to it.
The letter is a Northland MAP programme is on the top of the piece of paper.
Yeah.
So I think she's just weight management.
Oh, okay. It's
What's it on?
the weight management advice. That's it. Is that what you're asking about?
Yeah. Yeah. Has
Okay.
the standard handout been created yet?
I can't see where it says that there's a handout. Are you talking about page 2, the bottom paragraph? On
No,
page
no,
this one.
A single piece of paper.
Oh, the DH2 one.
Sorry. So Aneva's still working on that, so that hasn't been completed yet.
Okay.
So it's in progress. Sorry.
Okay, no worries. So I'm just trying to understand the process, and I look at, so for me, this is I'm focusing in on this because I've got my first client coming next week. So all of a sudden, I'm extremely interested, and I get the idea. So I've got to do an hour's assessment, and then there are going to be 5 other sessions over 8 to 10 weeks. Green prescription. Is that something I'm going to do, or the GP going to do?
So that would normally happen at the general practice end.
Okay,
so,
right. So he will have done that already. Yeah. Okay. Cool.
Yes.
You can
And
check.
then-
Green prescription is actually a self-referral program, so if it wasn't actioned, then it would be appropriate
to get them to do it. Yeah. Okay, all right, so I'll get them to do it if it's not done. Okay, the weight management stuff I can't do because I haven't got the standard handout. And the clinical pharmacist will have got involved. How will I check that? Will I ask the patient, have you seen a clinical pharmacist?
I think basically what we've got here is they're just interventions that can happen at the level, so it doesn't.
Oh, so it's not happening. It's not happening to everyone.
No. What every patient would have an individualised care plan. It would be up to you to discuss with the patient what's appropriate for them. They make a choice.
So if I chat to them and I think they need the clinical pharmacist involved, I have to try and organise that. So I have to say to someone, who would I say, hey, I think they need a pharmacist review? Who do I go to? How do I do it?
When you provide a session, there is a box in there for you to provide some notes back to the GP. So your recommendations could go in there if you thought it was appropriate.
Okay.
And you get the option to do that at each session.
All right, thank you. You can imagine I haven't done it, so I'm starting to think, oh my God. Okay.
These are just a guideline. They're not. You've got to tick off each option. They're just there for a guideline. It's at the end of the day, it's up to your individual clinical judgment what's required, and working with your patient around their need. The program is meant to be flexible enough for you to make some decisions around.
Okay. Cool.
So I suppose we're at a stage where, thank you for your feedback, that's really valuable. Is it, for those of you that have been already providing the service, is there anything good that you want to report, that some of the good things that are going on about the program?
Yeah, I've done 2 initial assessments now and 1 follow-up, and they were both really, I think, appropriate referrals, and they were both really grateful to be on the program and, appreciative and kind of looking forward to it. I find like I said before, the computer, the IT platform is really pretty simple and straightforward, and I've managed to just do it, with the patient and sort of send it off, so it didn't take a lot of time at the end of the session.
Right.
So it's really, really early days. But yeah, I think it's great.
Oh, well, thank you. Is there any final comments?
Yeah, I just got a new referral, and I think by the sounds of it, it had actually gone through the process quite quickly. So I think the lady was only seen by the GP last week, and then by Friday, sort of, I don't know, a few days later, we were able to contact her and say, what about this, make the time to see you next week. And she was saying, oh wow, so quick. And she was really motivated.
I think you'll probably find that will happen with a lot of our tahi level patients, which is obviously level 1, because they're more in that mild sort of stage of needing therapy. So that should happen reasonably quickly.
Yeah.
Right.
Can I just say something? Just looking at talking about doing steroid injections in Rua and Toru.
Yes.
Is it in training people up with musculoskeletal positions? There's a number of us who actually do them, who've got a lot of sports medicine training, so that step can probably be skipped. And Simon Wilkinson and I, and so the GP in Raumaga works with Ron. The doctor in Auckland. Conlon would be another one who'd do steroid injections with his eyes closed as well. So I don't think you probably need to train many people. There's quite a number here who would be very competent at doing steroid injections in joints. And ironically, those of us who have done sports medicine spend most of our time injecting, probably very, very little time injecting our athletes.
Excellent.
The ultrasound for a shoulder or the ultrasound guidance.
Wonderful, because ACC pay for the first one, but they won't pay for any more after that. Well, you can apply for it. It takes them about 3 months to approve it, and half the time they do, on one side of the bed they've woken up on. So ultrasound is preferred, but there are studies to say it may or may not make a difference. The only thing that ultrasound may give you is that it probably helps you avoid getting it directly into the tendon. If you're not injecting when there's resistance, you shouldn't be.
Are you hearing okay in Kitty?
Yeah.
Yep.
Is there any further questions about the program or things that you would like to see happen just to make it a bit clearer for everybody?
I think GPs need to have a CME on it.
Okay.
I think the practice nurses do as well.
Yeah.
But if you're going to be the ones filling in the forms.
So we will be planning some more of these sessions going forward, especially around because the model will be changing. Basically, going forward, we're hoping in the next 2 weeks that we can put forward our new proposal for the adjustments to the model to the ministry, and once they've signed that off, we'll be in touch. But as it stands now, what the current information you have, you just continue doing what you're doing, and then we'll keep you informed as to the progress where we are with the changes. We're not hoping to make too many changes. The only changes we're looking at is cutting the multidisciplinary team process out because of the complexity of trying to pull that together within the locations, and hopefully working with our general practice teams for some decisions to be made at practice level around the doctor-nurse teams working together to get all the information they require for a good referral to go forward to the providers.
Do we know what pharmacy's role in this? On Rua and Toru, they're included in that? Is that
Yes. Yes, definitely there is a role for pharmacy in Rua and Toru, and then we'd have to work through how that happens without that MDT process. And I think with the practices that you're already connected with, that would probably work quite smoothly, but there are practices that don't have that connection with a pharmacist. So, Kitty, if there's no further questions, what we might do is close our evening. And if you've got if anything comes up for you, questions, you go away from here, please just contact Dre, give her feedback, because we want to improve the processes for everybody.
Thank you.
Thank you.
Thank you all for coming out tonight. Thank you. Grab some food on the way. There's plenty there.